Bismillahirrahmanirrahim. Question number 1. A 34-year-old woman presents with the pain and swelling of the right knee over the previous 2 months. Pain film demonstrates a well-circumscribed X one side lighting lesion eccentrically located in the subarticular region of the right distal femur. The lesion has a narrow non-sclerotic zone of transition, most likely diagnosed giant cell tumor. Okay, now thinking that this is giant cell tumor and this is aneurysmal bone cyst ABC. Now look here, giant cell tumor presents with plain film has a well circumscribed the giant cell tumor of knee joint. The well circumscribed X1 side lytic lesion on the right distal femur has narrow zone of transition, there's no sclerosis, and it is subarticular. So diagnosis giant cell tumor. So lytic narrow zone of transition and subarticular giant cell tumor. Question number 2. A 30-year-old woman presents for general bacterial fatigue and painful stiff knees. She is subsequently found to be anemic. Plain film shows a Erlenmeyer class deformity of the distal femur with cortical thinning. There are no erosions. Where the most likely underlying condition? Cottage disease. Okay. Now these symptoms is that when the patient has anemia and Erlenmeyer class deformity, then most likely diagnosed cottage disease. Erlenmeyer class deformity is also seen in thalassemia, but Gaucher disease is more likely to have anemia and Erlenmeyer deformity. Women with fatigue and stiff knees, this has anemia and shows painful film shows Erlenmeyer deformity of the distal femur with cortical thinning, diagnosed as Gaucher disease. In thalassemia, there is also Erlenmeyer deformity, but there is avascular necrosis of femur head also in thalassemia. Okay. But we'll see this afterwards. But now she has Gaucher disease, anemia plus Erlenmeyer deformity. Question number 3. Pain knee radiograph performed in X-ray emergency following a sports injury in a 20-year-old full power tooth effusion, small abdominal fracture immediately proximal to the fiber head. Now, deepening of the lateral femoral sulcus and anterior transcapital of the tibia, most likely underlying ligamentous injuries, complete ACL tear, because he has secant fracture of proximal fibula. So when there's secant fracture associated with ligament tear, then it is complete ACL tear. Now look here, the image just to understand. This is normal ACL, normal anterior cochlear ligament. This is now in tear. This is ACL tear, complete ACL tear. We cannot see the ACL ligament. The complete ACL tear. There is no ACL ligament. Correct. Now let's go in front. Non-visualization of the ACL fibers indicative of complete tear. Posterior horn middle meniscal tear is also seen. The major meniscal tear is also seen. Now this secant fracture. Okay, this secant fracture. This reverse secant fracture. This secant fracture. There is avulsion at the lateral aspect of the tibia. Again, this PCL tear, and this ACL is on another side. This is posterior cochlear ligament. Now, question number 4. CT scan of the cervical spine is performed on an intubated patient with restrained driver and a high-speed motor vehicle collision. This reveals bilateral C2 parietal fracture. What is the most likely underlying mechanism of injury? Hyperextension and traction. This is Hangman's fracture. On X-ray, bilateral C2 parietal fracture. Bilateral C2 parietal fracture. This is hyperextension and traction. Hangman fracture. This is bilateral C2 parietal fracture, diagnosed Hangman fracture, hyperextension and traction. Notice that the patient, look at the C vertebra and the lower vertebra. So obviously the patient has gone hyperextension and then traction. Hyperextension and traction upwards. So bilateral C2 parietal fracture. And then there are fractures and 5, 6 is Hangman fracture. 1, 2, 5. These two are Hangman fracture. Bilateral C2 parietal fractures. Hangman fracture. Well, these are all important. Question 1 or 2. Electroaxial subluxation, then flexor tear drop fracture, the shoal fracture, spinal process fracture, Hangman fracture, chance fracture associated with junior injury and organ joint fractures. You have. This is adline to axial subluxation. These both are adline to axial subluxation. This adline to axial subluxation. This is Bird's fracture. C1 Bird's fracture. This is flexion teardrop fracture. This is Clay-Scholl fracture. Clay-Scholl fracture, and this is hangman fracture. These two. This is Chance fracture, also associated with duodenum injury, and this is odontoid pec fracture. Odontoid fracture. So hyperextension and traction um, causes hangman fracture or bilateral C2 parallel fracture. Question number 5. A young parent suffers a fractured femur and acetabulum in a road traffic accident and undergoes intramedullary nearing and plate and screw internal fixation of the acetabulum. He is well under raised post-operatively when he develops acute shortness of breath and right side chest pain. A chest radiograph shows only a small right side period with most likely diagnosed fat embolism. The parent underwent intramedullary nailing and internal fixation, and then after that he develops short pressure breath through fat embolism. Question number 6. Of the lateral fibrous structure contributing to the stability of the posterior lateral corner of the knee, is most likely to be congenitally absent and not identified on MRI, being present in only approximately 2/3 of patients are acquired ligament. On lateral fibrous structure of the knee, is most likely to be congenitally absent are acquired ligament. On lateral fibrous structure of the knee, most likely to be absent, congenitally absent, are acquired ligament. Question number 7. A child present a dramatic accident emergence following a road traffic collision. The graph of the spine shows a horizontal fracture involving the vertebral body and pedals of L2. Associated injury to which of the following or brown organs may be likely duodenum. Now this is describing chance fracture. Chance fracture. A radiograph shows horizontal fracture involving the vertebral body and pedals of L2. Associated injury to which brown organ duodenum. The radiograph of the spine shows horizontal fracture involving the vertebral body, pedicel, and vertebral body of L2, associated in it with the following organ, the duodenum. What is diagnosed? Chance fracture. Question number 8. Middle-aged man with no significant medical history undergoes radiograph for pelvis for localized tenderness following a fall. Multiple longitudinal oriented 2 to 10 mm rounded densities similar to cortical bone are seen throughout the cancellous bone and diffuse symmetrical pattern concentrated on the sternum. Now here, multiple rounded densities longitudinal oriented round densities similar to cortical bone throughout the cancellous bone and concentrated around the sternum. Now they are concentrated in the pelvis. There is no fracture, most likely diagnosed osteoporosis. Multiple round densities similar to cortical bone are seen distributed throughout the cancellous bone in diffuse pattern, concentrated around the acetabulum and the pelvis, diagnosed osteoporosis. Question 9. A 30-year-old man undergoes total MRI for chronic anterior pain. There is no history of trauma. Cyclical images reveal an absent anterior labrum with a thickened medial humeral ligament, but is most likely diagnosed normal variant. On MRI shoulder, there is no history of trauma and there is absent anterior labrum with thickened medial humeral ligament, diagnosed normal variant. Question 10. Hip arthrogram for chronic pain that is worse when exercise, loss of femoroacetabular sulcus superiorly with an superior acetabular labral where the underlying condition camp femoroacetabular impingement because loss of femoroacetabular sulcus. The MR hip arthrogram, there is loss of femoroacetabular sulcus with associated acetabular labral underlying condition camp femoroacetabular impingement. Patient has chronic pain that is worse during exercise also. Question 11. Middle-aged woman with worsening lower lumbar pain with several hour history of progressive urinary retention, frequent incontinence, saddle anesthesia, and bilateral leg weakness. Which method of imaging would you recommend as most appropriate? MRI. Middle-aged woman with worsening lower lumbar pain with several hour history of progressive urinary retention, frequent incontinence, so there are spinal cord compression signs. So for that we do MRI to see the spinal cord, the region of urinary incontinence and fecal incontinence. Question 20. It's one sign lytic lesion within the scapula secondary to metastatic malignant spread, which of the following is the most likely to be spinal site of malignancy renal. Because lytic and spinal lesions are seen in renal cell carcinoma. Because spinal site lytic lesion within the scapula metastasis from renal. Spinal site lytic lesion within the scapula metastasis from renal. Question number 13. A fallen fragment sign is seen within a lytic bone legend, most commonly associated with the following: unicameral or simple bone cells. Fallen fragment sign is seen in most likely simple bone cells. Fallen fragment sign is seen in simple bone cells. Question number 14. Triangular or pie-shaped lunate on the AP projecting of the wrist is most commonly a feature of visual body lunate dislocation. Triangular or pie-shaped lunate on the AP projecting of wrist is most commonly a feature of lunate dislocation. Triangular or pie-shaped lunate on AP progression of wrist is seen in lunate dislocation. Another is spilled teacup sign.